So without further ado, I wanted to just sort of reiterate a little bit of what Dr. Wolin has already alluded to, and start to talk a little bit about some of the differences between functional and non-functional neuroendocrine tumors, review some of the symptoms that we see in the functional neuroendocrine tumors, and we're going to focus really on carcinoid syndrome and some of its complications. Also in dealing with pancreatic neuroendocrine tumors, which largely are going to be non-functional, so generally not associated with a clinical syndrome, but can sometimes be functional, and when they are, they can have really dramatic clinical presentations. We'll also talk a little bit about some of the symptoms of non-functional neuroendocrine tumors, and then finally just wrap up with some of the treatments for symptomatic neuroendocrine tumors. So as Dr. Wolin alluded to, excuse me, functional neuroendocrine tumors are really often associated with hypersecretion of a hormone. And so if it's, for instance, if you have a primary in the midgut, which is the distal small bowel, so this is going to be the jejunum or the ileum, generally speaking, this will be associated with an overproduction of serotonin. In contrast, if you have, let's say, a pancreatic neuroendocrine tumor, and again, if it is functional, some of the most common ones that we see are listed there. Gastrinomas can be associated with a very dramatic peptic ulcer disease, terrible secretory diarrhea, reflux esophagitis. Those with insulinomas have a very different type of clinical presentation. They can have, as you might think from the name insulinoma, that they're going to have very big issues with low blood sugars and glycemic control. Vasoactive intestinal peptides and VIPomas, as we call them, often can have a very profound diarrhea that land people in the hospital repetitively. It's almost a cholera-like picture. And so all of these different syndromes or different possibilities depending on where your primary tumor is located and depending on the hormone that is being oversecreted. So the symptomatology will really depend on what hormone it is that you're talking about. Some neuroendocrine tumors will oversecrete more than one hormone. So although there's usually sort of a dominant hormone that is involved in any particular neuroendocrine tumor, we do see that sometimes there can be hormones that are co-secreted. And then the other thing is that you can certainly have a functioning tumor, which is one type of association with a clinical syndrome, but then you can also just have high levels of hormones that don't actually correlate with any clinical symptoms or don't correlate with a specific clinical syndrome. And so I would say that those are really two different things, whether it's a functioning tumor that's recognized with a clinical syndrome or whether you just have high levels of hormones which may or may not be associated with a syndrome. Those high levels of hormones without a clinical syndrome are generally considered to be rather non-functioning tumors. Now, I would say here that this is where, location is really key. And so whenever possible, we really do try to identify the site of the primary. And so this can be a variety of different locations, and this is where we have really some differences between the type of cancers that we see and the type of cancers that some of our other colleagues see. So as listed here, you can see, for instance, neuroendocrine tumors from the stomach, neuroendocrine tumors from the small bowel, nets from the rectum, nets from the pancreas. There are certainly many other locations, such as the appendix, the lung, the thymus, many other places that we can see neuroendocrine tumors. And again, depending on where these are, they may or may not be associated with a clinical syndrome. So for instance, the gastric nets here that you see in the left, there are three different types. Type 1s and type 3s are the most common. I would say type 1s a lot more commonly than type 3s. And those are generally going to be non-functional. Those are not associated with a clinical syndrome, certainly rarely associated with anything like a carcinoid syndrome. In contrast, type 2s are a different type of gastric neuroendocrine tumor. These can be associated with MEN, one of our genetic syndromes, and also can be associated with Zollinger-Ellison or gastrinomas, and these can be highly functional, which may again present those very dramatic findings of very severe peptic ulcer disease. And so understanding where the tumor is coming from, what type do you have, this is going to be a very important delineation. Also for small bowel neuroendocrine tumors, so people can have them from many different sites, the duodenum, the jejunum, and the ileum, and sort of going from north to south, and south being closer to the rectum, north being closer to the mouth. The duodenum, is going to be the first part of the neuroendocrine, the first part of the small bowel. The jejunum and the ileum will be sort of the lower 2/3 to 3/4. And the duodenum generally is going to be non-functional tumors. If you do see a functional tumor there, they often are going to be gastrinomas, where you have an association with excess gastrin. As the duodenum sort of changes over into the jejunum and ileum, these patients then start to have the carcinoid syndrome, and you're going to have this excess serotonin, the flushing and the diarrhea that so many of you are already familiar with. Rectal neuroendocrine tumors are something that we're seeing more and more these days, especially with the advent of colonoscopy for screening for colon cancer. These are tumors that every gastroenterologist really is now becoming more familiar with. Luckily, a lot of our patients who are diagnosed by gastroenterologists do quite well from the rectal neuroendocrine tumor standpoint. I know that our colleagues in oncology see different brands of rectal and colon neuroendocrine tumors that can often be much more aggressive. The ones that we see in the rectum, typically, again, non-functioning. You would not expect to see a carcinoid syndrome or overproduction of hormones. And then finally, pancreatic neuroendocrine tumors here. Again, the vast majority will be non-functioning, will not be associated with a clinical syndrome. When they are, you can see neuroendocrine tumors producing or overproducing insulin and gastrin, which will lead to very dramatic clinical syndromes. So in thinking a little bit more about small bowel, let's say, neuroendocrine tumors, and talking about the clinical presentation, just in terms of common to rare, the way that we rank it is the ileum is going to be the most common. The duodenum, again, the northmost part of the small intestine, will be the next most common, and jejunum is generally the least common of the neuroendocrine tumors of the small intestine. We are finding a lot more of these asymptomatically, so people are coming in for colonoscopies. If you have a gastroenterologist who happens to be dipping into the small intestine on the colonoscopy, then sometimes you're finding these what we call incidentally, sort of by accident, as the colonoscopy is being done for colorectal cancer screening. Now, this is only going to happen if your neuroendocrine tumor is very close to the border between the small intestine and the large intestine. There's a lot of small bowel that's north of where we can get to as gastroenterologists, and so there's no sort of saying or confirming for sure that you can definitely get a diagnosis of a ileal neuroendocrine tumor with a colonoscopy. In terms of some of the symptoms that we see extensive fibrosis from excess serotonin, and so this can manifest in a variety of ways. Abdominal pain, obstruction, I put in red here because this is often a very urgent issue that needs to be evaluated urgently and then often operated on emergently. GI bleeding and anemia. A lot of our patients sometimes present with some form of gastrointestinal bleeding, needing blood transfusions. Because the neuroendocrine tumors often occur in the small intestine, which can sometimes be a lot more difficult to access than, let's say, an upper endoscopy or colonoscopy, because you're trying to get to that area between. It can be very difficult to make a diagnosis of these neuroendocrine tumors in the small intestine. Similarly, they often can be very small. Dr. Wolin had shown a picture before of a liver, let's say, with a lot of metastases. And so you would think that if let's say, a liver has a lot of metastases, that the small bowel tumor might be easy to pick up, but often the small bowel tumors can be the size of a pea or smaller. And so you've got these little tiny primaries in the small intestine and then these very big lesions in the liver. And so that difference can make it very difficult to identify where the primary is. Many patients with metastatic carcinoid, again from the small intestine, can present with abdominal pain and require surgery. We've spoken before about the mistaken diagnoses that can also occur and sometimes lead to a delay in your diagnosis. There are a lot of things that are much more common than carcinoid that produce very similar symptoms. And so irritable bowel syndrome, inflammatory bowel disease, and specifically Crohn's disease, all of these can mimic the symptoms that we see with carcinoid syndrome and therefore can lead to a delay in diagnosis. Carcinoid syndrome, which I think the majority of medical students and residents who are being trained these days, they read about in their textbooks. This is really going to occur in a minority of patients. And so while it's the thing that we think about when we think about carcinoid, flushing, diarrhea, the syndrome, it's not something that you're always going to see when a patient comes to see you. And so I wanted to share with you a slide here that was courtesy of David Metz from the University of Pennsylvania. And this really sort of brings home to you some of the overlap that you can see between carcinoid syndrome and some of these other gastrointestinal conditions, again, which are much more common. You're going to be seeing that watery stool. Perhaps you'll be seeing some diarrhea at night, which I think is a thing that will definitely distinguish this from irritable bowel syndrome, where that's uncommon. Rectal bleeding, we're not usually going to see in our patients, but we certainly can can see if you're having enough diarrhea, you often will form a fissure or something at the anus that will start to bleed. And of course, flushing is a very common manifestation that we see in syndrome, but we don't usually see in these other conditions. And then abdominal pain and pain relieved upon defecation are other things that we can see as well. As I mentioned, this is really going to be rather the minority of patients with metastatic disease, and generally, again, will be duodenal and ileal neuroendocrine tumors, not generally from duodenal neuroendocrine tumors unless you are in the very end of the duodenum. Flushing, that carcinoid flush, is something that we certainly see quite a bit of. Telangiectasias, which are sort of dilated blood vessels that you can see in the skin and sometimes in the face and on the chest, are very common manifestations. Diarrhea, certainly all of you know, sometimes there's this sort of need to know where the bathrooms are, and so this is something that we see in a lot of our patients. Carcinoid heart disease, and this is primarily going to be a right-sided disease, and so this is going to be, let's say, sort of involvement of the right-sided heart valves, so the pulmonic and the tricuspid valves. And so this is a very common thing that we see, or I should say not a very common thing that we see, but certainly we need to look out for in our patients with carcinoid syndrome. In terms of looking at serotonin in carcinoid syndrome, we can use different kinds of markers. And so serotonin is a sort of a nice marker because you can get it from the blood. It does have some variability, and so there are some ups and downs to it that sometimes are not really related to the fact that your tumor is growing or shrinking, but just the fact that it can be very different from day to day. Urinary 5-HIAA can be a very good marker. It's a 24-hour collection, and so it's a little bit cumbersome for our patients. Again, this is not going to be useful for our foregut and hindgut, so it's only going to be useful for the midgut, which is the small intestine, and specifically, I would say, for the jejunal and ileal lesions. You can get a lot of false positives. By far, the most common thing that we see in terms of people having elevated levels here is that they often have eaten something that has contributed to the fact that it has been elevated. And so we mentioned that there are a lot of clinical manifestations, and we do think that these are caused by serotonin, by other vasoactive substances such as bradykinins and others. And the thought here is that the serotonin is going to enter the systemic circulation, particularly with liver and ovarian metastases. You can see here, this is the, excuse me, if we can just go back for a second, the tryptophan. If you look at the tryptophan to 5-hydroxytryptophan to serotonin sequence that's really depicted there, you can see that there are some enzymes that are responsible for catalyzing those enzymatic reactions, and that is what we're going to look at when we talk about Zermelo or Talotrostat, which is one of the agents that we use for diarrhea. Oftentimes, the development of syndrome and the severity of it can depend on the volume of disease and the location, and so this is another thing that's important to keep in mind. As many of you know, the carcinoid flush, it can be very troublesome and can often be triggered by many different substances, whether alcohol, foods, and cheeses, certainly by physical exertion, certainly by emotional distress. One of the things that Dick Warner actually used to tell me about also was differentiating menopause from a carcinoid flush, and he would always call it a dry flush versus a wet flush. It's certainly not 100% type of thing that you can use to distinguish them, but generally speaking, the carcinoid flush does tend to be a drier flush. The menopausal ones tend to be a wetter, sweatier flush. Again, we see some overlap there, so that's not 100%, but it's something that he's taught me many years ago and has always stuck in my head. And looking at the small bowel in terms of some of the abdominal fibrosis and some of the complications you can get, again, many of our patients with metastatic carcinoid will present with abdominal pain and require surgery, and there are all these different manifestations that you can see in the abdomen. And so you're not only dealing with the fact that you have a tumor, but also dealing with all of these after effects and complications. So the mesentery is sort of like a curtain that is sort of overlying your small intestine, and oftentimes when there is fibrosis in that area, you can have issues with recurrent obstruction. And so some of our patients are needing to go to the operating room multiple times to relieve these obstructions. There are also some very important blood vessels in that area, mesenteric vessels, and when those vessels are entrapped, you can have issues with severe damage to the bowels or ischemic bowel. And then finally, retroperitoneal fibrosis is something that we also see. And this is usually when there can be issues with the way that the kidneys are draining, again, from some of that scarring and fibrosis. And this can lead to hydronephrosis, which sometimes has to be addressed with different kinds of stenting and other things by our urologic colleagues. The importance here is that some of this can then make people, let's say, ineligible for other treatments, such as PRRT, because you're going to need a good kidney function, a good creatinine clearance to be able to tolerate that treatment. And if you're having issues with these fibrosis issues in the abdomen, this can then render you ineligible. So these are important things to keep in mind as well. Carcinoid crisis, I think, just deserves a word here, certainly because it's potentially life-threatening and often can be under-recognized. Flushing, dealing also with hemodynamic changes, and oftentimes in the operating room, severe wheezing. Again, will occur sometimes with administration of anesthesia when they're inducing the patient to go into the operating room. Certainly if our surgical colleagues are starting to open and starting to manipulate the tumor, that can also precipitate a carcinoid crisis. I have seen it occur just a few times during endoscopy, and so we, at the Mount Sinai endoscopies, we always have octreotide on hand to be able to do this during our upper endoscopies and colonoscopies. And you're going to see this occur just from a surge of serotonin and these other bioactive amines that sort of are released into the bloodstream as these sort of physiologic stresses are happening, to a given patient. We do administer octreotide. I have a protocol for prophylaxis and treatment of carcinoid crisis. All of the doctors at Mount Sinai are extremely aware of this complication, unfortunately, usually having sort of encountered it at one point or another in their career. And so if possible, we try to avoid some of these agents that can sometimes also contribute, but unfortunately, especially with those patients who are undergoing, let's say, a cardiac valve replacement for carcinoid heart disease, these medicines often become necessary and are certainly key players in our management of these patients. Just wanted to move briefly to pancreatic neuroendocrine tumors. As I said, a lot of times these can be non-functioning tumors. They can present with more advanced disease because they're relatively silent. You can get symptoms from mass effect, meaning that if it's just a mass sitting there but not actually secreting any hormone, you can have symptoms listed there. So certainly pain is a very common symptom. Jaundice, if there is blockage of the bile drainage that's going into the intestine, that can be, you can start to turn yellow. Weight loss and pancreatitis. Again, because people are getting scans for so many different reasons, we are seeing an increased detection bias from imaging, and so hopefully this will lead to some patients being diagnosed a little bit earlier just because they're getting imaged for some other reason. I wanted to share with you again this slide. I think the important thing again is the insulinomas and the gastrinomas are on the top there because they're most common, but we certainly do see cases of these other ones, glucagonomas, somatosanomas, and VIPomas, which also can occur. And so in thinking again about some of these available therapies, we are very fortunate in this field to have very strong collaborations between multiple different kinds of experts. And so this has really led to major strides and major evolutions in how we treat them. And you can see here that there are really lots of different available therapies for tumor and symptom control. I would say that a lot of these we really think about for tumor control, but a lot of them will also alleviate symptoms. And so these are things that I think are important to know because we're trying to do two things at the same time. In terms of symptom control at the bottom there, somatostatin analogs certainly are going to be very helpful with carcinoid syndrome. We'll get really briefly into the tryptophan hydroxylase inhibitors and as well as endoscopic therapies. And so in looking at the tryptophan hydroxylase inhibitor, otherwise known as telotrestat or Zermelo, again, you're blocking that step from tryptophan to 5-hydroxytryptophan, which then is involved in going to serotonin. And so because you are blocking these steps of getting to serotonin formation, you're now able to lower your serotonin levels. And so this will assist in those patients who have severe diarrhea from carcinoid syndrome, which are not being addressed adequately with somatostatin analogs. Medical therapy, I think, also deserves a special mention for those patients with gastrinomas. High-dose PPI or acid blockade is really critical to make sure that these people stay out of trouble. We don't want you getting into intensive care with life-threatening gastrointestinal bleeds, and so with these different treatments, we've really been able to get much better control. Diazoxide is an agent that we sometimes use in those with insulinomas, again, to help us with glycemic control. I also just wanted to make a brief mention of some endoscopic therapies that we can do. And so there are things like alcohol ablations and radiofrequency ablations that we can do for especially those patients with pancreatic neuroendocrine tumors who have insulinomas and or gastrinomas. There are lots of case reports. Case series are often in small institutions and smaller numbers, I would say, because these are not very common things that we do. But if patients are too sick for surgery, if they're refusing surgery, they're medically refractory. These are things that we can do endoscopically, and so this can be an outpatient procedure, and essentially we are injecting alcohol around a tumor that is over secreting a hormone. We can often get patients much better that way. And similarly, radiofrequency ablation is a newer kid on the block that can be done in some of these patients as well. So just to close up, again, we can think about neuroendocrine tumors as functional or non-functional depending on the clinical syndrome that's associated with them. That primary tumor location is really important in understanding what clinical syndrome is likely to occur, what can you expect. Often will also help us in predicting how people will do long term. The rectal, gastric, appendiceal, all of these are going to be often non-functioning. The midgut ones will usually be functioning, and that's usually going to be associated with your carcinoid syndrome symptomatology. The PNs are often going to be non-functioning. And then just to remember that we do have lots of treatments, not just for tumor control, but also for symptom control. Thanks very much.